Outset, I would like to thank the RATCON Scientific Committee, especially Dr. Subindra and Dr. Suel for giving me this wonderful opportunity to be part of this exciting meeting. Despite I saw the very tight academic schedule, they managed to squeeze my talk in vascular eye session. I'm very grateful to all of you. So I think we all have realized that there has been a lot of development in interventional radiology. And the HPB diseases, HPB field is not an exception. Because of this development of IR facilities, I think our IR friends have been helping us to share the responsibilities and the burden of work with HPB surgeons, and we are very grateful to that. But over these years, as working as a GI HPB surgeon, I have realized that now when you have too many options, it creates a lot of confusion regarding the choice of the first preferred treatment. So we always have that complexity in decision making. So I realized that I think I can discuss on some of these important components of HPB diseases where we have some, I don't say exactly it's a debate, but there is some confusion regarding which treatment options should we prefer first. So I have selected some of the important the areas that I would like to discuss in the next 15 minutes. The first important aspect is management of small SCCs. I heard that you all had a very good symposium yesterday, and there was a lot of discussion on, I'm sure it's on these small SCCs. It's because if you see the treatment options for SCC, especially the early stage tumors, which are small tumors, less than 3 centimeter tumors, look at these various treatment modality options, which all can act as curative treatment options: the ablation, transplant, and surgical resections. So this makes us creates a very complex, situations which one to choose first. But I think it's very our smartness that we need to take into consideration these various factors: the patient-related factors, the liver-related factors, the tumor-related factors, and especially in our country, we have to also take into consideration socioeconomic factors to make any final decision while offering these treatment options. Now, having said this, no one would disagree with me that the liver resection still holds the #1 treatment curative option, which has the longest overall and disease-free survival. We have plenty of studies and available literature to support this statement. As you can see, as high as 10-year survival has been achieved with liver resectional surgery. But I'm not saying that the ablative therapy is less enough in comparison to surgery. There are plenty of studies which have shown very good this overall survival. But if you realize this, if you read this, most of them has focused on 5-year survival. Then I think it's still time to wait to see even a longer survival in terms of overall and disease-free survival. So till this time, I think the surgical resection still holds a better long-term overall and disease-free survival. And on top of that, if you look into the guidelines from various societies, I think almost all these societies keep surgical to resections, the ablation and transplant as the treatment options, but all of them has kept their first priority as resections. So what we do in our practice for all small SSAs, we always offer resection as far as feasible. If the patient is not a surgical candidate, we go for ablation. And then if the patient has associated portal hypertension, decomposition, our first priority is to offer liver transplant. We've been offering treatment for SCCs in our hospital. We are backed up by our excellent interventional radiologists, Ajit, Dinesh. We are very fortunate to have them with us. So we have from ablation, from various radiological procedures to transplant, all kind of services are available in teaching hospital. Although some of these, as I mentioned here, are not available. And surgical resection for hepatocellular carcinoma has been one of the commonest indication for doing liver resectional surgery in our setup. And we've been able to achieve a good long and short-term outcome in these patients. Now, next important one is the benign biliary stricture. Yeah, in the morning I raised this issue regarding the preference of the surgery versus IR dilatation for these patients. Strictures means there are two conditions. One is post-cholecystectomy bile duct stricture. The second one is stricture following bilioenteric anastomosis. The Bismuth classification, which is also a component of a Strasbourg classification, is used for classifying post-cholecystectomy biliary stricture. If you carefully see this image, the lower one strictures, the B1, B2 strictures, can also be accessed by endoscopy. So there is a debate between endoscopy versus surgery, and for the higher strictures, B3, B4, 5, there's a debate between the IR versus the surgical bypass. There are plenty of studies. I do not disagree that for these B1, B2 stricture, the endoscopic therapy has been stated as the best possible option. But if you realize these all come from the Western society in a very big developed centers, and they have achieved more than 97% resolution rate for this stricture. But the main problem is it needs to be repeated. It needs repeated sessions, and it may take like sometimes even 1.5 to 2 years for a complete resolution. That's the problem with endoscopy. On the other hand, the studies coming from our part and our neighboring countries like India, there you will find plenty of these evidences regarding the surgical bypass for these patients. One very important study, although published quite long ago by a very well-known surgeon, Dr. Sikora, 292 patients had undergone hepatic ostomy, and 149 patients had 5-year follow-up, and 90% had great outcome. And one meta-analysis back in 2017 looked into these various IR endoscopy versus surgical treatment, and it compared, and the final outcome was, although there was no statistical difference, but it was seen that the highest long-term success rate was provided by the surgical bypass. IR dilatation and endoscopy, I think as I said, it needs a repeated session, it takes time, and which actually increases the cost of the treatment. And more than that, I think although we are now lucky enough to have so many IR specialists all over the country, but still the number of IR facilities are still limited. So we have to be very careful in selecting these treatment options. The next, for post-cholecystectomy biliary stricture, I think the surgical bypass is the preferred one. It's because it's one-time treatment, and we do have evidence that we can provide excellent long-term results. Although you may disagree by saying that surgery is a morbid procedure, but when done by an expert HPB surgeons, I think morbidity is very minimal. We've been providing surgical bypass for all these bile duct injury cases, although the volume may not be so high, but around 16 of these patients who had undergone hepatic ostomy in the last 10 years, I have not seen any recurrence in my follow-ups. The other important stricture, as I said, is a stricture following hepatic ostomy, biliary bypass done for various situations, whether it's for bile duct injury or for like hepatolithiasis or choledochosis excision. So there is always a risk of stricture formation, and if you see the incidence, it's quite varying depending on center to center, of 5% to 70% risk of stricture formation after hepatic ostomy. Now here I don't disagree that here the IR dilatation is preferred as the first option to dilate this stricture, because surgical revision on these patients who are already been operated is quite challenging. Not everybody can do it, and also the complexity increases the morbidity of this patient and sometimes even increases the mortality. So most of these evidences, as I've quoted, they all have preferred the IR dilatation as the first priority, and then followed by surgical revision in the patients where we fail to dilate by these IR procedures. Having said this, I'm not again saying that the surgical bypass is not an alternative option, although everyone would prefer IR dilatation. But this very interesting study is coming from India, and 23 redo HJs, they followed up for 8 years. Almost 74% were symptom-free with zero mortality and very minimal minor complications. That means we can always keep this surgical bypass also as an alternative option. And this can be backed up by with this, I think this, the similar outcomes following a percutaneous intervention versus surgical revision. You can see both of them have achieved a similar outcome even in patients who had undergone revision hepatic ostomy. We have a very limited experience in terms of repeat HJs for these bilioenteric anastomosis. I have just done 4 patients who had undergone IR dilatation and then they developed repeat stricture or failed stricture, so I had to re-intervene and re-operate on these patients. But luckily all 4 of these patients have been doing well till now. So how we do it, all post-cholecystectomy patients, for all first post-cholecystectomy stricture patients, we always prefer surgical bypass, and if it's not feasible, non-surgical candidate, then only we go for either endoscopy or IR dilatations. But for bilioenteric anastomosis, we will, as a surgeon also, we prefer IR dilatation as a first priority. The third important component is gastric varices. And I wanted to discuss this, that these days I see our Dr. Ajit doing a lot of BRTOs. And I looked into the evidence, are we doing the right thing or not? I think he's doing absolutely the right thing, treating these via these large gastric varices. What we mean by varices means by occluding them with these IR facilities. But there is still a debate on this. Why I wanted to raise this is I looked into the evidence of this IR obliteration of these large gastric varices. It's very interesting to know that the BRTO can obliterate 100% of these large gastric varices and can control this acute bleeding. But the problem is the rebleeding rate has been stated very high, as high as 31%. But more than that, the problem is that after occlusion of these large gastric varices, the esophageal varices increase, and over the time, if you see, the risk of bleeding can increase as high as 90%. So we have to be very cautious in selecting these patients for occlusion as well. Because as far as we have facilities to go for surgical procedures for like shunt or devascularizations, which has been backed up by these various studies, again coming from India. This one from, again is from, I think it's from Gangaram. 25 PSRS proximal spinal shunts were done for patients who have large gastric varices, and these patients were all non-cirrhotic portal hypertension. And it was seen that there was 80% variceal regression in a long term. So how we do it then? That means I think I personally prefer shunt or devasculation for patients who have gastric varices or with esophageal varices in patients with non-cirrhotic portal hypertension. Those who have failed recurrent bleeders after surgery and who are not surgical candidate, I would refer to Ajit and other IR specialists for balloon retrograde, this transvenous occlusion of these large gastric varices or other IR procedures. The surgery for portal hypertension is a common procedure that we have been doing in our department. More than 100 shunt or devascular surgery has been done for patients who have gastric and esophageal varices. And we have been providing both shunt and devascularization in terms of HISAPS procedure. And over these period, only 6 patients have come back with recurrences. Our recurrences rate following the shunt procedure or devascularization is very low. So what I say is, as far as possible, I think we would prefer to go for the shunt or devasculation in these patients. You may disagree with me. The last but not the least, the important one again is a hepatic hemangiomas. Hepatic hemangioma is the large hepatic hemangiomas. We have options of observation or surgical resections, or my IR friend would say we can treat it with IR interventions, and we have medical treatments as well these days. But what I want to say is, no matter the size of the hemangiomas, if they are asymptomatic, you don't need to fiddle around. You don't need to toss these hemangiomas. In the past, there are a lot of surgeons have been operating on hemangiomas, but the size doesn't really matter. As long as patient is not bothered, no one should be bothered tossing these hemangiomas. We have plenty of evidence. This one, although it's from quite long ago, 1995, more than 163 hemangiomas were observed for more than 92 months. And it was seen that only in 4 patients where hemangiomas more than 20 centimeters had complications. But otherwise, all other hemangiomas did not create any complications. So we have to be very careful in selecting whether to resect or to intervene in these patients with large hemangiomas. So these are some of the pictures of our patients who had presented with symptoms, severe symptoms, and with very large hemangiomas, and we had to resect. But more than that, what I want to say is this is one of the patients, a young female, I say is in 30s, and I've been following her up for the last 10 years. Look at the size of the hemangioma, and she is still in follow-up. I have plenty of other patients who are on follow-up and had not developed any complications. But what about the IR procedures for hemangiomas? I came across so many IR procedures, from ablations to IR embolization with the use of chemicals, chemotherapies like bleomycin. I found, there has been good reports in terms of case reports controlling the symptoms. But the problem is it can control the symptoms by decreasing the size, but it does not remain for constant. So it has to be repeated again, and it can never cure. So I think in patients who are not surgical candidates and the patient is very much bothered with the symptoms, maybe this group of patients can be benefited by IR intervention. So in summary, what I can say is patients with symptomatic hemangiomas, what we have been doing, if it is asymptomatic, it's really bothersome, we would first offer them as surgical resections. And sometimes, it's a very big ones. We ask our IR to embolize first, and the next day we resect them. But if the patient is a not surgical candidate, definitely we would ask our radiologist to help us for IR embolization. And if it's not embolizable also, then we would refer them to our medical friends to treat them medically. So at last, I would like to summarize whatever I have said. This is my take-home message. For all small SCCs, I think resection still holds the first preferred treatment, surgical resection, as long as the patients are surgical candidates. For biliary stricture, post-cholecystectomy biliary stricture, biliary bypass is the standard treatment option. But for bilioenteric anastomotic stricture, the IR first followed by surgery is the gold standard treatment. For large gastric varices, as far as possible, shunt or devascularization is a priority in patients with non-cirrhotics. Okay, please mind it, it's a non-cirrhotics. And in cirrhotics or other non-surgical candidates, we will refer to our friends. And all symptomatic hemangiomas, asymptomatics, don't touch. All symptomatic hemangiomas, resection is first. With this, I would like to finish my talk, and I'm very happy to take any questions if there is any. Thank you so much. Thank you.